All right. Well, welcome everyone to this meeting of the Board of Directors of the Health District of Northern Larimer County. Today is Wednesday, August 19th. And let's have a roll call of board members, starting with Director Field, who is online.
Judge Field, Julie Field, treasurer of the board.
Thank you. How about we go, Sarah?
Sarah Hathcock, secretary.
John McKay, he, him pronouns, and I am the PDH liaison.
Lee Phelan, vice president.
Then I'm Board President Erin Hottenstein. We do have a quorum, and so we will call this meeting to order at 6:01 p.m. We always like to go around and hear who's in the room. We'll start with staff, and then if you have any members of the public, we'll get to them in a moment. So Allison, if we don't mind.
Allison Williams, she, her pronouns. I'm the Senior Director of Strategy and Impact.
Rebecca Toll, she, her, Senior Manager of Integration and Partnerships.
Dana Turner, she, her, Senior Director of Community Health Services.
Katie Haynes, she, her, Project Strategist.
Susan Kaiser, she, her, Director of Practice Innovation and Quality.
Jessica Holmes, she, her, Finance Director.
Hi, Courtney Green, Deputy Director of Operations.
Wonderful. How about over to Brian?
Brian Ferens, he, him, Executive Director.
Michael Oliver, Information System Specialist.
Juan Gonzalez, third party, helping with the meeting today on the IT side.
Wonderful. And then what about online?
So on the meeting, it looks like we have a few people from the health district. Heather, Marissa, Mike, and Rosie, along with, I believe, one member of the public, Celeste.
Okay. And I also see Elizabeth Laboon, who is.
Yes, Ellie Laboon, she, her, legal counsel for the health district.
All right. Well, welcome everyone. So let's move on to our conflict of interest statement. Board of Directors, pursuant to the bylaws, please disclose any known or perceived conflicts of interest related to any agenda item. The Health District is committed to preventing the personal interest of the board, employees, and independent contractors from interfering with their duties to the organization and avoiding any unethical, financial, professional, or political gain on the part of such individuals. Board members, do any of you have a conflict to declare?
None.
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 No.
And I don't either. All right, wonderful. So moving on to the approval of the agenda. Do we have a motion to approve the August 19th, 2026 meeting agenda as presented?
So moved.
Second.
All those in favor?
Aye.
Aye.
Any opposed? And the motion carries unanimously. Thank you. All right. So we're going to do public comment a little bit differently tonight. Just a heads up that we're going to have two opportunities for public comment. This is the first opportunity right now. The Health District of Northern Larimer County Board welcomes and invites comments from the public. Public comments or input are taken only during the time on the agenda listed as public comment, and it is an opportunity for people to express their views, and therefore the Board of Directors generally does not engage in a back and forth discussion or respond to questions. We ask that you keep your comments to a time limit of 3 minutes for each individual. If you choose to make comments about any agenda item or about any other topic not on the agenda, please use the following guidelines. Before you begin your comments, please identify yourself. Please clearly spell your name for the record and let us know if you reside in the district. Tell us whether you are addressing an agenda item or another topic. Please address your comments to the Board of Directors rather than individuals. Do we have anyone who is interested in making public comment at this time?
If we do have any members of the public wanting to make public comment, please raise your hand in the Zoom call.
Thank you. Anyone online, would you like to raise your digital hand in the Zoom meeting? All right, I want to give them time to fiddle with their with their laptop, okay? All right, seeing none, we will move on the agenda. And like I said, we will have another opportunity for public comment later in the meeting. So we have a presentation on the sliding fee scale, on the sliding fee scales.
Hello, everyone. Can everyone see my slide deck?
We're working on that. Okay, we can see it in the room.
Okay. My name is Ray Wolf. I am a lawyer from the West Virginia area, and that I have been working in the industry for some time. Pronouns are he, him. I moved from law practice very early in my life to work with healthcare and became chief finance officer at Pittsburgh Mercy Health System, and where I worked for 22 years and worked with that organization as it grew from about 10 million to about 150 million when I retired. Retirement didn't go well for me. I wasn't happy, and I decided to move into contracting and was offered a position as senior associate with Open Minds. During that time, I worked with strategic planning, law and other work, and basically mergers, acquisitions, and a series of business-related activities. The agenda for this presentation is very brief, but it does include some key topics. One, I'd like to just describe why it is that your staff and I have been working on this particular theme, and why we're proposing that a new model of patient fee allocation is being proposed. Two, we'd like to explain the basics of it, how it fits industry standards and is reasonably common throughout the behavioral health side of the industry, at least. We have a proposed model to present. The model is simply a proposal. It is an outline, a high-level outline of how this will proceed. I expect that if adopted, it will be 2 or 3 years of adjustments and slight changes to get it to the way you want. But I believe it's a good first step down the path. At that point in the presentation, I will sit back and allow your staff to complete the budget linkage and discussing of next steps. So what we want to discuss today is developing a proposed standardized sliding fee discount scale that would be used across the company in all its units and for all its services. We would create a base rate for people in the service district that would be benchmarked against Medicaid. No one would pay higher than the Medicaid level. And we want you to have the background information necessary so that you can review and approve the details of the discount process that we're proposing during the upcoming budgeting cycle. We want you to consider some of the elements that we discuss and their impacts and policy effects, because we'd like for you to be able to adopt some related governance policies that would allow this process to move forward. So why should we adopt a sliding fee scale? There's a lot of verbiage on the slide, but I'm thinking that there are three reasons in my mind that it makes sense. First, from my legal perspective, there are duties and responsibilities with being a board member. There are requirements of how you need to behave and the kind of approaches you need to take with activities that come forward in front of you at the board, particularly when you're talking about a board that is heavily involved in tax allocation and moving cash around to benefit the people in the area and to try to do it in an appropriate way. There will be, and there are always problems and differences in making sure people are handled correctly. But it is so much easier and more defensible if you have a system in place that determines in an objective manner how monies would be allocated to help support people in need. And that is objective, it is visible and transparent to the community, and it applies to all the services in your domain. Without that in place, with decisions even being made with the best of intentions, there will be inequities. And eliminating those inequities is a good step forward for the board. The second reason I think is just ethics. We want to do the best we can. We want to make sure that the dollars that are raised by this district are used in the most optimal way to reach the most people and to do the most good. And this process allows us to step back a little bit from folks of higher income, still providing discounts, but slightly less, and allowing that to work in a way that we would see a more optimal impact. The transparency, the equity, the access to care will create an atmosphere where the likelihood is that Colorado regulatory standards will not affect you over time, and you will probably have better brand reputation as a result of having this level of transparency and this level of activity. The financial impact of the model we're proposing is not measured. 80% of your current clients are covered by some level of public insurance. They won't pay anything because that public insurance will cover their service. They may have non-covered expenses, very severe situations in the dental department with if a cap is exceeded or frequency issues can cause problems. Uncovered charges and other areas can create unforeseen debts for people. And those would be handled in a way that allowed the person some level of support and alleviation for the difficulties that they would have. About 20% of your money represents self-pay income. And this discount process, we believe, will be approximately close. It won't be substantially more profitable for the district. It won't create a financial hardship for the district. It will be in the ballpark. And like I said, we will implement this at a fairly high level, and the finance department of your organization can make those decisions as you move along, and will fine tune the model to a better outcome. It is our intention that the sliding fee would cover all non-covered expenses, even for those with public insurance, if that should occur. The bottom line, it's equity, it's transparency, it's a defensible framework backed by regular industry standards. And this presentation will get us to a place where we can move ahead with that flow. So the sliding fee is something that is used in federally qualified health centers. It's used a lot in behavioral health centers. It's been adopted for all sorts of health-related activities across almost every state. And it ensures people that have financial hardship that they will pay less for services. The tiering of the pricing will always work down to the federal poverty level, which is tiered based on the size of the family. So what may be a poverty level for a single person would not be the same for a family of 5 or 6. So those kind of factors are worked into the flow. When we looked at common regulations in your state and in the region, we found that the family size was important and was mandated in many applications. Equitable application across all persons served was mandated. Coverage for persons up to at least 200% of the federal poverty level, and written policies. What was not required in anything we saw was a mandated scale or a specific method to develop that scale. And that's the work we kind of focused on the most. So once again, self-pay is assigned a fee discount based on income and family size. Public insurance will be accepted for all clients, and there generally will be no out-of-pocket expenses. If there are, for some reason, those would be self-pay amounts and would apply. This is the model that we developed based on the information we had about the federal poverty level and the estimates that were done by members of your staff to kind of develop a flow. On your left, you will see an indicator of family size that goes between 1 and 8. Next to it is the federal poverty level based on that size. For example, that a single person earning less than 15,960 is considered in the poverty level, whereas a family of 4, people under 30,000 would be considered that. And the methodologies for this are maintained in the federal government and the Department of Health. From that, we decided to create 5 levels of discount, moving between 100% of the federal poverty level or below, all the way up to 400% of federal poverty level. Level A is those people who do not hit that level that you see shown. So for a 3-person family of 27,320, if you make less than that, your discount will be for all services 100%. If you fall in a range between 27 and 41, basically if you fall between 101% of the poverty level and 150, you will be somewhere between that 27 and 49.80. Your discount in that case would be 80%. 150 to 200 would be a 60% discount, 200 to 300, a 40%, and a 20% discount for those people earning more than 400% of the poverty level. This will work out to adjust correctly for individuals based on family size, and it will still allow for self-pay billing and responsibility for persons seeking services who rise above the appropriate levels. As I noted, it is kind of standard and expected by regulations that we would look at a family-based federal poverty level. It is based on regulations that we should go to at least 200% of the federal poverty level. But all of the other elements have basically been decided along the way and have been tested somewhat in the budgeting process to determine that there would be no serious impact, either positive or negative. The positives around this, I think, are the discounts being appropriate to the levels, a single organizational wide system, but in addition, the idea that if you decide to grow in the future and potentially move to supporting third party revenue, bringing people into the organization who will pay more through their commercial or private insurances, that can be supported and built into the structure as well, simply by changing the rates. And it may be that profit from persons such as that will help offset the cost of service to others. I would have worked for the Sisters of Mercy for some time, and I perfectly understood their model that they were here for those most in need, but they didn't mind taking donations from others to support that concept. One of the questions that we received in this is why to use Medicaid as a benchmark? And there are several reasons. One is the Medicaid rate does have some investigation, some theory behind it, even though in recent years it has been basically seen to be far away from the idea of cost. But the idea around the original structure is that they would look at reasonable customary rates. They would look at the amount of effort and equipment necessary to produce a certain service code, and they would use that information to estimate provider cost. And that's where the Medicaid rate was set. Medicaid covers all of the services that you provide. So using Medicaid means that every service will have some item. Some may feel it is inappropriately low, but they will all have a relative comparison to each other. It's a place to start. Many organizations over time move to 120% of Medicaid or more as states have adjusted numbers inappropriately downward or to match budget concerns and issues. That is generally the structure. Before I drop off to allow the budget discussion, I was wondering if there were any questions about the layout and the way to do it. I would add that we have done your staff has done a great deal of observation of work at the front desk. And we found a lot of folks who were very, very dedicated to trying to do the job right. But because of staff turnover and structuring, training, and the consistency of rules simply hasn't been there. So one of the benefits that we're hoping with this will be a consistent application at the front desk, regardless of the program that you arrive to work through, that will allow the organization to really show to the community the sense of equity and fair play that they have and their transparency about their rate structures. So with the,
Sorry.
Sarah has a question.
Thank you so much for this presentation. This is absolutely wonderful, and I love that we're talking about this. So important. And one of my questions is, because I know that one portion of our utilizers of health district services are underinsured families that have kind of catastrophic insurance but are having to pay out of pocket until they meet their very high deductible. So avoiding services for like behavioral health, for instance, because they can't afford those services, even though they are insured. How would those families be able to utilize this, and would it be accessible for them?
yes, it would.
Scale?
The standard methodology and path for that would be that you would first bill their insurance. You would get a notice from their insurance that they had not met their deductible, and the amount would be then moved to self-pay. Once in self-pay, the sliding fee would automatically apply. It's our thought that everyone being registered at the front desk would have some of the structured paperwork that Colorado provides for this, and that we would know their family size and their family income, and all of that would be recorded in the computer system. To a degree now, it is very widely used already. So when a bill, let's say there was $1,000 bill, and the insurance company said you have a $10,000 deductible, that $1,000 bill would fall to the family, but it would immediately look at their discount level and reduce that bill before it went to the family to a much more appropriate point.
And would they be able, when seeking services prior to actually choosing to move forward with services, be able to know exactly what will be out of pocket for them? So they go in
Yeah.
there wide open. Okay.
And you can provide outreach information based on this to people and to explain to them how they can estimate their charges so that it isn't even necessary for them to arrive at the front door. They might be able to see it through forms and paperwork available at other facilities.
Thank you.
So I guess my question is I'm wondering how we could potentially think about this differently related to the self-sufficiency level of income that actually applies to our area. Because the national poverty level is set every January and it's national. So it's based off of cost of living across the United States, where we know in Colorado that we have a high level of cost, and in northern Colorado. So using an index like this actually in a way doesn't have necessarily the threshold to get to 100% covered in a way that I think is actually realistic for the cost of living to our area that the health district serves. So if we know that the um, national poverty level index the self-sufficiency level of income might actually be 2 times, even 3 times that of what the national poverty level index shows, then how would we be able to create a system or a sliding fee scale that actually represents what it costs to live here in northern Colorado and our area that we serve at the health district versus using a nationally normed index that doesn't necessarily take into consideration the specificity of what it costs to live here in northern Colorado.
A good point.
Yeah, very good point. And it is frankly something that has come up in many locations and many areas and state. The simple answer to your question is what we're proposing is that we adopt a uniform standard with a policy around the percentage of discount and our estimation of where poverty level stands. We are not saying that that's where it will stand forever or that your rates should be structured that way for a long period of time. This can be adjusted on an annual basis. Once in place, you may make the decision that because really your area is more like the 200% level, you could increase that 0% domain out to the 200% and adopt that as a change. Or you could choose to put in your own poverty level if you can find a good objective source that finds it. Either way, you could make sure that the people in your area have bills that are reasonable and commensurate with their ability to pay. I really think that you, in the first 2 or 3 years, are more than free and would be wise to consider changing the percentages and the discount levels and those other elements where you have complete control, and to do so in a way that satisfies the needs of the people in your community. It's up to you to fill in those blanks. We have met the very broad standards of most regulatory agencies, and the actual dollar amount charged can be adjusted this way so that everyone in the same situation will be impacted the same. So feel free to adjust it appropriately once it's in place.
Have you worked with areas with concerns like this with high cost of living? And do you have an approach you would recommend or?
I worked at one point many years back. Yeah, back quite a few years, and I won't discuss how many, but I worked with some folks in New York City. And I worked with some other folks working in the Philadelphia region when I worked in Pittsburgh with Pittsburgh Mercy. And the Philadelphia region had substantial issues, and as did New York. And their approach was simply to take the 0% category and move it out to the 200 or 250% range in order to be fair to the people in their area.
Brian, do you know if there's any regulatory limitations that would prevent us from not doing that now? Because I'm not sure why we wouldn't consider that. If we're gonna institute and implement,
Yeah,
why wouldn't we do
I-
that now?
I'm not aware of any that would prevent.
I think
us from
you're
doing
gonna
that.
tell me maybe why.
There are, I know of none that would prevent it. I have standard policy that I don't expect extra work from finance departments having once worked there during budget season. So I'll leave it to you to make that directive. But if you would like to see it expanded out and the 0% moved out, that's certainly something that can be done.
We can absolutely look at making those adjustments. We did build two things already into this fee schedule that try to account for the cost of living in our area. The first is extending the discounts all the way up to 400% of the federal poverty level. And that was done based on looking at the area median income and trying to extend the scale out further than most places do. The other piece that will be in place, and I think maybe Jessica will talk about it, is a standard application and write-off policy for people who maybe don't qualify for one of the standard discounts, but do have additional financial hardship because of cost of living or other circumstances, and that will be available to everyone.
Thank you.
Thank you.
And as part of your research, this self-sufficiency index, is that what you called it?
No, it's just a self-sufficiency level, and
Oh,
you can
okay.
you can
That tool.
look around it. There's not a specific tool. Actually, it's pretty hard for Northern Colorado sometimes.
Okay.
We make broad assumptions, and then you have to look at all sorts of different types of data to be able to establish, like, what would we want to conclude
Mhm.
as to what that means and how we want to apply it to a sliding fee scale. So
Yeah.
it really isn't as easy as looking up the
Right.
poverty level
Right.
that is
It's
established by
Yeah.
the feds.
And I'm just wondering did you come across any other healthcare safety net programs in Colorado, in the area that utilize that type of data instead of just FPL?
Instead of FPL. So across the board in the research, everything is based on FPL from what I found, which is why we were recommending FPL and taking again into area median income and bringing it up to 400%. So it seems like all hospital systems, even nationally too, really base everything off of FPL. And at the minimum, like Ray spoke to, things can go up minimally to 250%. Some hospital systems may go all the way up to 600% in some cases, but the average is really landing around 400%. Most of the research is in the hospital area, not community health centers.
The
The other-
hospital,
Oh, sorry, Ray, go ahead.
I was just going to add that hospital levels tend to go higher because hospital bills tend to be bigger. So they have an impact on people even at higher levels of income than you might. I am not aware of anyone using another standard. I think if they did exist and they were evidentiary based, that it would be fine. But it's the simpler matter is simply to adjust the percentages in each area than to try to make adjustments that may or may not have a true impact or an evidentiary base. So that can be done quickly and adjust forward.
And I'll just add that we can choose any starting point, but having something standardized that we can actually look at the data coming in to say, oh, has everyone at this level been applying for additional financial assistance and write-offs? Maybe we should change the percentage. So we're thinking about leveling it, and we could make adjustments to what's here based on feedback today. But if we start here and periodically look at how the additional write-offs are coming through, we'd use that information to make further adjustments.
Yeah.
Any other questions or comments?
Just a quick one to staff, really. I assume you've looked at what our partners are doing in the community.
Yeah.
And have a sense for that as well.
Me too.
I'm not saying it should be exactly the same, but just so we're aware of what
Yeah.
they're experiencing at the community clinic or other things. Yeah. Thank you.
Mhm.
Anything else?
Is there more to this presentation? Okay,
More on the
Great.
budgeting side.
Okay.
let's do
And then
that.
I-
and then More questions.
All right, so we
Do you have clicker?
It's up there.
Okay.
I just want to make a note on the time that we think we have about 4 minutes left on this, which, okay.
Fast.
Impressive.
Oh, thank you. Okay, so it's a lot of information. And it's a lot of numbers to dig through. And based on your question, I was actually looking at a different standard called Alice standard, which actually accounts for the actual cost of living. It's asset limited, income constrained, but employed. So we can look at those numbers. They do have some numbers for our area, and we could see how that compares. But this is basically setting up the structure. And we can change those, we can change FPL to whatever we want and then apply that discount. The important thing is that we adopt setting the Medicaid rate as our base rate in all of our various EHR systems that we're working to,
Sure.
unite. It's very standard. Any other healthcare organization I've worked with, that's part of the budgeting. I don't ask Dana to tell me how much revenue she thinks dental is gonna bring in or behavioral health services are gonna bring in. I say, what do you think services are gonna look like next year? How many patients do you think you're gonna get to take care of? And she gives me that number and then I figure out the revenue based on Medicaid. So that's what we're moving towards. And what you'll see in the budget package is just an extra supplemental information page that'll say, it'll have those Medicaid rates and our schedule. And so you don't have to know all of the specifics of all of, getting into all of the numbers, just that we're using the Medicaid rates and applying those based on whatever income standard we use. And it makes budgeting easier because you're just budgeting based on services and then updating those rates as Medicaid updates. But we will update once a year, not every time Medicaid updates. So within the budget, it's not that you'll see a whole bunch of information on all of the different amounts for different services. You'll just know that this is what we're projecting for services and these are the Medicare rates. So in 27, it's gonna be, as Ray had mentioned, it's gonna take a little bit to get it right. There's always gonna be budget variances, but I would expect that more so in the first year. Because 80% of our service revenue is Medicaid based. And those rates will actually increase on certain services. Decrease on others, increase a lot on others. They're our current rates are all over the place right now. But because that's the bulk of our income, from services, our service revenue income, not the bulk of our income. I would expect any increase on the Medicaid side to offset the fact that there are going to be further discounts on the self-pay side. And then in the areas where there aren't, that's where we're gonna be a little more proactive with client assistance in 27 because we're aware and sensitive to the fact that some self-pay, especially more on the behavioral health side, might see increases because of being set at the Medicaid rate. So that's where we'll come in with client assistance funds to offset that. And we can certainly look at adjusting and not using the federal poverty level. I know I was looking at that chart of what the federal poverty level actually is for various family sizes, and yeah, it's very low. So did you have any questions on what you're going to see with the budget or financial projections?
Thank you.
Thank you.
Thank
you.
Thank you.
Thanks.
I do just want to thank our team for
It's great
taking
work.
this on. This was a huge lift. So Jessica, Sue, Katie, Dana, open minds, like for us to get a standardized structure for our sliding fee scale, and have that foundation. And I think it's the affordability question is a great discussion to have in terms of like those levers that we want to tweak. But it was a huge lift to get the health district to, I mean, a lot of research and investigation on current practice. So thank you for
Thank you.
Thank you.
putting this in front
It's like a
of us.
big improvement. Thank you.
Yeah.
Yeah, if I could just add a couple of comments, can you hear me?
Yeah.
Oh, okay. Just, yes, thank you. I really am, of course, all about standardizing procedures and practices and really appreciate that. I do like that it was 400% of the federal poverty line, but I also think we should look at the ALICE standard because I do think that gives more information locally. And I want us to be, as we go forward, let's get this in place this year. I'm excited to do that, but I want us to consider being generous as we possibly can in the percentage discounts as we go forward in every category. So just putting my stake in the ground for yay, this is great. So excited for this opportunity. And thank you, Ray and Jessica and the rest of the team for everything that you've done on this.
Great, thanks.
The work done by your staff was amazing and it was substantial. And I want to thank them for that effort moving forward. This is a first step, a beginning on a pathway. I think you have ideas and insights about what directions you want to go from here, but just getting to the point where you have a framework will allow a lot of innovation and development for the future. Thank you all so much for the opportunity to be helpful to you, and we'll see you later.
Thank you.
Thanks, Ray.
Thank you, Ray.
All right, if we're ready to move on to the next agenda item, we have the consent agenda. Do I have a motion to approve the consent agenda consisting of the June 17th, 2026 regular meeting minutes?
So moved. Second.
So moved by Sarah, seconded by Lee. All those in favor say aye.
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 Any opposed? Hearing none, that motion passes unanimously. All right. Next item. Well, if I can flip the page. All right. So we're moving on to the FNBO CD account closures and signatories for financial accounts. Do we have anybody speaking to that, or we're just going from what we read in the packet?
We don't have anybody presenting on
Okay.
that, so it really is just open for discussion, questions
Okay,
before voting on the resolution.
wonderful. Dear board members, who has questions or comments on this item?
It looked to me pretty pro forma. It's
Okay,
Julie has her hand
yeah,
up.
I see Julie now.
Yeah, again, going back to my stake in the ground of making sure that we're standardizing things, I think this is an excellent improvement. It's something that's been needed for as long as I've been on the board, and my understanding is long before that as well. I know as the treasurer, I've seen some of the challenges that have come up with having a named person on the account rather than a defined role, that has led to people lingering on accounts for several years past the time that they were in the role or even worked for the health district. So this is something that is well past. Just very excited to see this implemented, and as you know, think that the staff has done a great lift in sort of bringing this to the fore and making sure that we are carrying out what we need to be doing, which is making sure that we are standard in our practices and procedures, because we need to be doing that throughout the organization. And so this is building on things that have been occurring since I've been on the board. And I really do appreciate this approach in this area. So thank you.
Thank you, Julie. So just want to check it, because I think when I read it, it applied to all financial accounts. Is that correct? Because the title on our agenda says FNBO.
Yeah.
Yes.
It applies to all of them.
Oh, okay. All right. That's what I was thinking, but I was like,
Good catch.
wait. Yeah, because we started moving this over to titles a couple of years ago. And so my second question is, will this handle it, or do we still have some more kind of cleanup that we're moving toward?
This covers it, and yeah, the resolution actually doesn't address FMBO.
Right.
That's the agenda
Okay.
title, so it
Great.
covers all financial accounts and is a comprehensive policy.
Okay, awesome.
basis.
Yes.
Thank you. Yeah.
Suckers too.
Yeah, ever since I got on the board, I was wondering why we had to keep dealing with safety deposit boxes. So, all right, cool. Those were my questions. Any other questions or comments? No. All right, do I have a motion for approval of resolution 2026-09 as presented?
So moved.
Second.
Okay, seconded by John. Moved by Lee, seconded by John. All those in favor say aye.
Aye.
Any Any opposed? Julie, I'm sorry, I didn't. hear.
Sorry, my internet keeps going in and out. I'm assuming there's been a motion on the resolution.
Yeah, so I was just calling for, all those in favor of this resolution, say aye.
Aye.
Okay, come on.
And any opposed? And so the motion passes unanimously. Thank you. All right. Then moving on to the Board Public Policy Committee item that's on page 13 of our agenda. So we had some positions that we took essentially online in between meetings. And so we're just bringing these to the rest of the board to get your ratification, unless you have comments or questions or concerns. So does anyone have comments or questions on this item? Okay, hearing none. Do I have a motion for approval of the Board Public Policy Committee update as presented?
So moved.
I'm sorry, I do have one question.
Okay.
I just can't help it.
All right, hang on one sec. So let's just get a second. So we have Julie moved it and then the second.
A second.
Sarah's the second. Okay, now what's your question?
I'm just curious on the tobacco retail licensing. There was something in here about proximity and being able to, can someone explain what that is?
Proximity of retail shops to
Yeah.
schools.
Is it to schools? So it's not of individuals to,
Right.
okay, so
Yes.
this is specifically for vendors. I'm just concerned about profiling, and so I just want to I don't want to create an opportunity for additional profiling.
Yeah, it's for shops and vendors.
Okay, perfect. That's all I
Selling
need to
tobacco
know.
products.
I just wanted that clarification. Thank you.
Great question. Any other questions or comments? Okay, hearing none. All those in favor of the motion to approve this update as presented, say aye.
Aye.
Any opposed? And the motion carries unanimously. All right, moving on to reports and discussions. We have Ms. Holmes with Q2 Financials.
And she'll do Q2 financials and budget timeline kind of all in one. So
Alrighty,
Sounds good.
sounds like a plan.
And I had gotten the memo on, you know, keeping the time on this too, so it is very much a summarized presentation of what you see in the board packet. So.
Oh, wait.
Oh.
Sorry.
Get to stretch my legs. That's true. Feels good.
One more.
We'll just admire the branding while we're waiting. Look at those pretty swirls.
Marissa's on, I'm sure she would appreciate hearing that.
You would. Go first.
Okay, so you might have noticed that there are two balance sheets in the financial statements this month. And it is year to date and prior year to date. So it's the change from the end of 25, which is important to see, you know, what's happened so far. But some of the variances being so large can look a little scary sometimes. So I think it's important to see right now compared to the same period of the prior year. So when you're looking at both balance sheets, what you'll notice is that year to date, cash and investments have increased by almost 3.5 million, which is up 24% since the end of the year. But from prior year, it's only up 1.4 million, or 8%. And those same kind of trends carry in total assets, where year to date assets going down, big number looks, you know, doesn't look as good. But if you look at the prior year to date and you see that it's really close, it's just because of our tax collection cycle. And that same thing carries true on deferred inflows. And fund balance is it very closely mirrors the cash and investments, because the prior year to date change in fund balance is really close to prior year to date change in cash. And that's just because of you know, we're at the same point in the year on our tax collection cycle, and that's just the cash that has been kind of retained still from that point in time. But the most important thing on there is that the unrestricted fund balance is over 19 million. Budgeted monthly expenses are at about 1.45 million, and that gives us over 13 months or 403 days of cash on hand. On to revenues, expenditures, and changes in fund balance. In the financial packet, you'll see year to date compared to budget and by function, just so that you can kind of dig into all of those numbers at various levels. But revenues overall, they are on budget. There's a 20,000 variance, which is less than 1%. Expenditures are under budget by 1.8 million or 20% so far year to date, and the vast majority of that is in personnel compensation savings. In addition to just there being vacant positions, we're also taking some measures in our budgeting strategy for 27. So if we know a position is vacant, not budgeting for it for the whole year, budgeting for it when we expect it to be filled. So that'll really help with that variance. And also, you know, space being an issue, we have to have the room to hire the vacancies as well. So the change in fund balance so far, we are ahead of budget by 41%. The year-to-date change in fund balance has been 6.24 million, and that brings us to our total fund balance of 19.87 million. Another statement that is in your packet that's new for this quarter is the rolling forecast. So most of that I've been doing in the background and just not really providing the statement on it. We just kind of talked about it at the meetings. So once you have a few months of actuals into the year, then you could start seeing the trends and projecting out how you think the rest of the year is going to go. So at this point, I'm projecting that our total revenues for the year will be slightly ahead of budget, but still within 1%. And expenditures, I think they're going to go up. You know, I think that percentage gap of the 20% is gonna come down a little bit, but just to about 19%. I'm expecting that will be underspent from budget by about 3.4 million. And that will put us at a positive change in fund balance of about 1.67 as opposed to our planned deficit of 1.8. So that is quite a large variance from what we planned. But we're very aware of why we have those variances. And the more important thing is what we do to manage the fund balance going forward, and how we adapt our budgeting in 27 so that we don't have as large of variances and can have a closer, you know, alignment of finances. So does anybody have any questions on any of financial statements, anything from the packet?
So I mean, the reason why is because of vacancy?
Mm-hmm.
And do we know what our current vacancy rate is, budgeted and posted?
It's in here.
I think I had it in the memo, what it currently is. I know it had dipped a little bit right towards the end of June, but then it went back up. So that was just kind of some normal, like, couple of normal positions that turned over. And then I know there's also other positions that are currently in the hiring process too, that aren't even reflected in that. So it is going up, it's just, you know, all of those positions were budgeted for the full year. So.
Yeah, I think that some governmental budgets actually factor in vacancy savings. And so I'm glad that you're taking a look at some other way to show a more realistic
Yeah.
expectation. Yeah.
Yeah, and historically, I think we always used. Like, we had all the positions budgeted, but I don't know that it was. That filling all those vacancies was always a problem, so we continued doing the same thing, even though the problem was changing. So, definitely want to
Keep an eye on that one.
reevaluate that for 27.
When I think that we've had significant turnover in the last year. So I think it's difficult to say what is the data that we'd rely upon to even budget for a vacancy rate. So I think it needs more time to kind of see how it starts to play out before you can start determining and start budgeting for a vacancy rate.
But I think your approach makes a lot of sense, which is if you know you're not gonna fill a position until 6 months, or you're guessing, whatever, then just adjust it. Yeah.
Yeah, that's, I mean, not so much like a rate and everything, like a vacancy rate, but more so of. We have a lot of vacant positions in, you know, the same departments or programs where. We know those managers aren't gonna be able to hire for all of those staff members at the same time. So if they could just kind of plan out their year of when they're going to, you know, get to hiring that position. And it also helps too that we've already been working on work plans. So, that will, and the purpose of that was so that we could use those in the budgeting process so that, can have more accurate budgeting and not be, over enthusiastic about what we're going to get to accomplish in 1 year when we're doing the budget, so.
Yeah, we kind of have multiple things happening. We have existing turnover of existing positions, and getting that rate would be helpful to understand what our turnover rate is. And we have a fair number of positions that were budgeted and have never been filled and still aren't filled. I mean, 15 maybe, you know, somewhere that as we budget for 2027, if we carry over some of those new positions that didn't get filled, we're probably not gonna budget them 100% in January, because if we're not gonna post for them until January, you're not gonna hire them and start paying them probably till February, March. So some of that's strategy. So we kind of have two vacancy things happening where, and you know, we haven't been some positions we are still contemplating, do we need this position? Do we want this position? And that'll come with our budgeting process. Others, we don't have room,
That's
you
the
know,
issue.
physical space for some of
Can't
them.
do
And
it
so, yeah, so those are some of the factors, but yeah, the vacancy rate is, there's like two things happening there.
Well, and there should really always be two
Yeah.
vacancies, one
Mhm.
overall budget.
Yep.
And then what you're actually posting for and trying to hire.
Right,
for,
yeah.
Right, and so I think you have to look at both of them, because I think overall vacancy can
tell
be
different stories.
misleading,
Yeah,
really.
right.
And so,
Because they're not posted.
well, yeah,
Yeah.
you're not even recruiting for them,
Right.
so are they, I mean, are they truly
Yeah.
a vacancy,
Right.
I guess?
Yeah,
Maybe
exactly.
in there, yeah.
And I do have a quick question about that. When we are posting and actively recruiting, what is the timeline? I know that's a difficult question, but are those filling?
Like the average.
Yeah, as far as once we post.
We have average.
That's a tough question.
Really.
No
depends
worries
on
if
the
you-
Position.
Yeah,
I mean,
position.
dental hygienists are very hard to find, so those stay open
Yes.
for a long time. Psychologists, hard to find, although, yeah, we had one start on Monday, which is very exciting. So it depends, and I just wanted to remind everybody that when we budgeted last year, we budgeted positions that we had in 2024, knowing that 2025, knowing that 2026 was going to still be a year of discovery, but we kept them in the budget in case we discovered that we needed all of them, and I think we're still in that discovery phase.
Yeah.
It's a good reminder.
And of the ones that are posted and just sitting with challenges to fill, dental hygiene, is there, and then psychologist, which is there another one on the list that's really just kind of laying vacant because of lack of applicants? So.
Do you have any bilingual specific positions that have been sitting? No, okay.
I think, as of today, there were 400 applicants for our data analyst.
Oh my gosh.
Yeah.
That's abnormal.
A lot of them
amazing.
Wow.
to be AI.
I love
Okay.
the senior account positions.
Wow.
Oh my gosh, even I was getting emails about the senior accountant position.
Yes, I got it.
Numerous emails about that. But that was spam, so don't worry about it. So, yeah, what I'm appreciating about this is the continued refinement that the organization has been doing on the budget process over the time that I've been on the board. I mean, everything's becoming more and more transparent. I mean, we used to have a contingency budget that had personnel in it, and that was kind of hard to suss out what was happening there. So this is getting more and more transparent, which, and this shift that you're talking about in the next budget process will make it even more transparent, which I really appreciate. So I love seeing that progress. I continue to be concerned about the fund balance. But there's plans on the horizon. So
Money could go fast.
I'm hopeful that we will continue to live into our potential.
I have one quick question. I noticed the compensation for the quarter included a one-time district-wide employee bonus. Was that based on percentage or a flat amount?
It was a flat amount.
Flat amount. I think that was a good idea for two reasons. One is retention issues, incentive, and the other to just recognize that this district has gone through a lot of difficult times.
True.
And thank you for being here.
Yeah.
So
Yeah.
I'm glad you did it.
All right, any other comments on this part? Did you have another part?
My next part is the budget timeline.
Okay, so any other questions on this part, dear board? Okay,
I think that's our new
Need
name.
to do that.
my dear board members.
Yeah, 2 deer in the yard today.
Okay, so it was actually a year ago that I was here in person for the first time presenting the budget timeline. So we have already done our internal kickoff. So we did start it a little bit earlier this year. It's kind of a difficult place because everybody wishes they had more time to work on their proposals, but if we go start it too early, we don't have any actuals, for them to base anything off of. So we have done the internal kickoff. And next up, everybody will fill out their budget proposal templates, and there will be numerous opportunity to review those with finance. I'm also incorporating the whole finance team this year. Everybody expressed a lot of interest in wanting to be more involved with this huge budget process that happens every year that they know nothing about. So everybody is involved this year to one degree or another. And then after all of the different departments and programs complete their proposals and they're reviewed with finance, and then we will move on to an internal review period where that'll be more of an executive review and adjustment period where Brian will review all of the proposals combined into what I call the master budget file. And then once we're through that, we'll prepare the actual package, which everybody is due to, well, not everybody, the board is due to receive on October 15th. And then after that point, public inspection is available. Anybody could come to the health district and review the budget. And then we will have the budget review meeting on October 21st. And public hearing in November. And then in December, that is when we will have all of the finalization pieces of adoption of the budget, setting the mill levies, and appropriating funds and external submissions. One caveat to this timeline this year in relation to board meeting schedule is that we don't get the final certificate evaluation from the assessor until the 10th. And I think the board meeting is currently scheduled for the 9th.
I'll change it.
So we need
That's
to,
not
Change
gonna
it.
work.
we need to either change
Yeah,
it,
we need to
schedule
change
a
it.
special, a second special meeting in that window, because we have to have it approved by the board by the 15th.
Yeah, so it has the certificate of tax levies have to be submitted by the 15th. The budget itself, submission isn't required until January 31st, but you have to adopt the budget before you set the levies, so.
Yeah, I think we should change the meeting. I think it's best to try and wrap it up all in one.
I agree.
Then we'll work on throwing out some alternative times. Days,
Great.
to reschedule that. Okay.
Just,
So-
oh, sorry. I had a question whenever you're done, Jessica.
No, I was gonna ask if anybody had any questions.
So my question is in the evaluation section where the budget is available for public inspection, you said people can come in and look at it. Is it also something we make available online?
We haven't in the past. I think like the way that it's always that it has to be available for public inspection at, X location. I think it's kind of up
Right.
to us if we want to just put it online, or if we want to have people go through the effort of coming in person, or.
Well, let me ask Ellie to weigh in on this as well. I think that could be helpful. I think we need to, in the spirit of making sure that we are standardizing our procedures and being available to the public and transparent. If we can make it available online, that's the way most people get their information these days, or that many do. And if we can open it up to public inspection online, we might consider doing that. I think that would be a great boon to the community and to our visibility in the community. But if there's some reason not to do that, I guess I'd like Ellie to weigh in and my colleagues as well.
Yeah, I don't see why not. But if I find a reason not to, I can let you all know beforehand. But yeah, I see your point, Julie, and I don't see a reason why not.
Julie, I appreciate the spirit of transparency. I think my only curiosity is, will we be able to provide enough context to the budget for people to truly understand and interpret what they're reading and not take it out of context, I guess. I don't know how else to say it. So I like the thinking. I just wonder if we are, as an organization, in a place where we've evolved there, that we can be able to articulate that well enough yet. I think that we're still learning about our budget. We're still learning about our operations, and I'm not sure if how would we articulate that? Would there be a video attached to it? Would there be a presentation attached to it? I'm just curious how we would articulate it. So that's my only curiosity. I love the
Yeah.
spirit of transparency, and I agree. I'd love to get there. I'm just curious, and I'd like to hear from the team at some point as to, are we ready for that or not?
Well, and I think the public can already inspect it. It's just
Yeah.
that they have to go through the steps of coming in person to
True.
look at it. And we have the budget is available for inspection. I'm looking at the schedule that Jessica sent out, October 15th meeting the next week. That's when we talk about it, and people that have questions can come to the public budget hearing on November 18th. So I don't know that we do anything different with the budget itself and the public inspection. I think that that conversation, we haven't had the conversation yet when that budget is posted. And so I think maybe attaching to the budget itself just a cover sheet of these are the upcoming budget deadlines and events that are occurring. And you have an opportunity for public input on November 18th would be a huge pathway towards what you're suggesting, John.
Yeah, no, I appreciate it. Yep, it's a good point.
Yeah, I do. I was all actually thinking about the same thing with like the context. And once you put something on the internet, it's out there forever and all of that. So I liked the idea about doing a video or like some kind of, you know,
Budget one.
yeah,
Budget
like,
message.
yeah,
It's a budget
like
message.
a budget message. And then we could
I like
also, I mean, it would even be an improvement, rather than, you know, putting it on our website, it would still be an improvement to let people ask for it digitally. Instead of, you know, we could still, you know,
That's good.
email it to them,
Good idea.
you know, let them, we
No,
can
that's-
send them the PDF or put it through some kind of secure link. But that would still be a step up from, you have to come here and.
Does it have to be a secure link if it's publicly available, I guess?
Yeah, that's
So
true.
I think these are questions that if it's publicly available, somebody can come in. I don't know if they can take a copy of it. Public inspection may or may not include that. Nellie may know the answer to that. Or it may be they just are able to look at it and take notes. But I think and if the video is the budget message of, hey, here's our budget and here are the upcoming dates for public comment and the board review and so on, I think that could be sort of that in between place where we're letting people know that it's available. We're letting them know in a couple of different methodologies, audio, video, and in writing on the cover sheet of the budget that this is available. So it's out there in our world and we have to make it out there. You know, yes, it's out there forever, but so is this meeting and everything else that we are talking about as a public agency. So I don't see the fear with having it out there.
We could also even engage communications to maybe do some posts.
Yeah.
kind
Yeah.
of
So I
raise
think
awareness.
we're getting a little bit into the weeds.
Mhm.
And I appreciate.
My thought is let's figure out how we can make it as available to the public as possible, and not just require people to get on the bus or to drive to the organization to actually physically look at it.
Yes.
Yeah, I just want to say I totally agree. I think for folks who have barriers to transportation and work hours that conflict with when we're open, to have it available in some other fashion is important.
Yes, I also support that. I remember we used to post change notices for meetings on the front door of the building. And, you know, there's no reason why let's keep moving things online, makes it more accessible, makes it more transparent. That's all good.
Yeah, and the in-person, just historically, that was because there was no other option. That's why people had to go to the courthouse to look at documents or had to come to a public agency to look at documents. But we've moved beyond that as a society. We should move beyond that as a health district.
Yeah. And the public inspection portion, versus online, I don't know that we would do any budget literacy education there with the inspection, like in
Right.
person. So if we're not gonna do that in person, why not just put it?
Yeah, so give them the deadlines, tell them when their next opportunity is for our next opportunity to discuss it, their next opportunity to give us their input, but that is what they're getting now. It's just a question of, is it more accessible if we put it online on the website? And I think it is, and I think that's what we need to strive for.
Wonderful. Okay. Anything else? All right, let's move on because we have some exciting things to talk about with partnership investments. So Jessica, thank you so much.
Thank you, Jessica.
Thank you, Jessica.
Okay. So we, Rebecca and I are here to present a framework that will guide how we invest public resources and community partnerships moving forward. It's about building a transformational partnership model, one that is intentional, transparent, and aligned. So we're seeking your guidance on framework and strategic direction. Okay, so really your role here is to establish clear direction regarding how our dollars and resources are invested to deepen partnerships over time. This direction acts as the guardrails to give staff the ability to act within define parameters and give the community confidence that public resources are being stewarded responsibly. Without those guardrails, assessment decisions default to relationships, history, or urgency rather than from strategy. And that's not sustainable or defensible.
So we had developed a framework that we believe helps answer 3 critical questions. The first one being, do we have clear processes for how we distribute funding and resources? To that end, our partnerships are best understood as a portfolio of relationships rather than a single category of funded partners. Across this portfolio, partnerships serve different purposes. They require different organizational investments and call for different levels of governance and oversight. The second question is, are we dispersing partnerships in a way that makes sense? As we examine that portfolio, are we investing across the continuum intentionally, or have our investments accumulated in certain areas over time? And then the third question being, are our partners aligned with our direction? So this framework specifically is supported by a robust partnership viability assessment tool that's used internally by staff to determine the appropriate level along the continuum of presence in alignment with organizational priorities, our strategic plan, and the mission. Here's the continuum. So we have partnerships mapped out along a continuum that increases trust, shared accountability, and community impact as we look at the portfolio of investments that we have in front of us. The inform and coordinate tiers are primarily about systems improvement. And that looks like better coordination, reduced duplication, and stronger alignment of services. The collaborate tier puts shared priorities into action. It's bringing partners, expertise, and resources together around specific opportunities and community needs. And then the integrate and transform tiers are looking at reshaping the system itself, aligning resources, services, sharing decision-making and accountability, and creating new ways of working together that achieve greater community impact. Every level of this continuum represents a real investment. Staff expertise, relationships, convening authority, organizational capacity, and dollars are all public assets that should be invested intentionally. Each level is determined with purpose. So partnerships sit where they best support the work and our desired outcomes, not based on longevity, funding amount, or the goal of moving up the continuum. Partnerships can evolve as the work evolves. A relationship may deepen, shift, or remain at the same level as needs, opportunities, outcomes, and shared accountability may shift. Thanks. Success is not moving every partnership toward transform. Success is having the right mix of partnerships at the right levels that help us achieve our mission.
Okay, so that first tier is really informed. So within this portfolio, it is our foundation. This tier ensures the health district is known, trusted, accessible. It's not like a pre-partnership, but it's really valuable investments in community infrastructure. So examples for this that are currently being done are going to events like Overdose Awareness Day, attending recurring meetings like Sharing and Caring, and attending like case manager meetings at the Larimer County Community Justice Alternatives.
when we look at our coordinates here, we're looking at individual initiatives that can really amplify each other's effects when they're intentionally designed to reinforce one another. That's what coordination does, and we're making the whole greater than the sum of its parts, excuse me. So a key question to ask as we're assessing partnership viability within this tier is, are coordination investments actually reducing fragmentation within the system? And examples of this would include our MHSU Alliance, the Regional Assessment Collaborative, or the Larimer County Strategic Plan participation.
And then when we've frequently tested the relationship at the tier of coordinate or inform, we're seeing alignments, we're making a bigger bet. We are seeing where evidence has supported making that bigger bet. And we combine our organizational capacity with flexible financial investments to accelerate shared work. So really here is where we start to sort of see that more clear board governance coming in, and that comes through the annual budget process. Some really key current examples are an upcoming partnership that you saw in the board updates about with Foothills Gateway on functional assessments, utilizing our psychologists on staff. And then also, if you've seen our social media or Homeward Alliance's social media recently, we worked to provide them with key hot weather necessities for those who are unhoused to be able to remain the most cool they could possibly be, with that cooling blankets. There was liquid IV, Gatorade. There was a lot of purchases were made because it was not being met by what they currently had or other donations. So really, we see this level for investment of being back to the sort of that one-time need for something like a community assistance project or client assistance needs, or something that can't be met with other types of funding.
Can I just ask a question?
Yeah.
Mid presentation, I guess if you could go back to collaborate. So I hear one-time need, but then I see multi-year partnerships.
No, they're not. Yeah. Yeah, the integrate now says somehow we went or mixed again somehow. So
You have a gremlin.
we have a gremlin.
Okay,
This typical investment is what we just talked about.
okay,
and how it got us.
okay, great, thank you.
Yeah.
Okay, thank you. Yeah.
Yeah.
So collaborate is not one-time funding.
Collaborate is the one time.
Collaborate is one-time.
Yep.
The text is not matching the tier, but yes, what Allison spoke to is correct.
Was that your question?
Yeah, I
Okay.
just, what I was reading, what I was hearing didn't seem to make sense, so I was just trying to
Yeah.
get clarification.
Yep, thank you. We made one switch yesterday on animation, and apparently that's
no problem.
some other
I get
pieces,
it.
so we'll get the correct version to you. All right, so as we move into integrate, which if you want to go back to the collaborate, it's great, pretend. Within this tier, we are really looking at aligning resources, services, and expertise around shared outcomes. So this is designing and delivering parts of the work together. Investment decisions consider the full organizational portfolio, including partnerships, direct services, and community priorities. Board governance increases at this tier, right? So we're setting policy and priority, approving significant investments, and overseeing strategic and responsive funding in this space. This tier currently includes partner funding through our contracts. So the FMC, Salute, Summit Stone, and PSD support that is happening right now, as well as the PSD Summit Stone Behavioral Health Referral Team Project, as an example.
And then we move the last tier of transform, which is really thinking about we're not just funding programs, we're investing in new ways of organizing around community health. Its signs of progress at this level look like completely different shifts. Shifts in narratives about what's possible, new governance arrangements, changes in lived experience, and even before system-wide indicators are moving. So the time horizons here are much longer, and the board's role is really that enduring and patient stewardship, not poorly scorecarding. So we don't have any current examples here because it really is it is transformative, which is a lot of work when it comes to partnerships. But as we're thinking about it, what this would look like back in the 90s is which moved from being PVH to the Durham Health District. That was a transformative partnership and move. So this next year from us, you'll be seeing it as a learning and growth year. It's really about these infrastructure pieces, learning, growing, that planned use study act approach to some of this work. And really seeing what the community need is and being responsive in that. So experts in the system change field are really clear. Change proceeds through pilots, learning cycles, refinement, and eventual institutionalization. That's what 2027 is. Our 2027 testing is essentially a set of probes, learning where and how meaningful intervention is possible. And you'll see progress reported through report updates, as well as the quarterly financial reporting. So key questions throughout this next year will be, are we learning where to intervene based on what we're discovering? So really thinking about those different tiers, where do we intervene and how? Is it with funding? Is it with thinking through how we are providing staff and the ability to do certain types of referrals? Is it investing more in how we're doing that informed foundational level? We don't know. So what you will see, that transition is really thinking about how do we move from who do we have a relationship with to what are we trying to achieve and which investments get us there. So the board's role is to own the framework, not the individual funding decisions. You're setting the what and the how much through your mission, vision, values work, the annual budget approval, and strategic plan goals. Staff really is going to bring the who and the how within those boundaries. What you'll be seeing in the budget is a funding request for partnerships that to support the collaborate, integrate, and transform tiers. And ultimately, success is a community that can see why we invest, where we invest, and trust that public resources are being deployed with intention, equity, and transparency. And that flexibility piece matters too. We know that our ecosystem is forever moving. And success isn't in rigidity. It is about creating this framework that can adapt to emerging community needs without abandoning discipline within the process of getting there.
So to that end, we are requesting board guidance in 3 areas. The first question is, does the overall partnership investment approach resonate? Does the continuum provide a useful way to think about the way the health district invests in different types of partnerships? And then the second question being, are the proposed investment parameters appropriate, particularly at the collaborate, integrate, and transform levels? Are we striking the right balance between flexibility, responsiveness, and stewardship? And our final question is, what governance and reporting does the board want to see at each level?
I mean, oh my goodness, thank you so much. Like, I am so excited about this. This is exceptional. This is something that I've been trying to understand how we would apply this. So this is clearly the roadmap that we've been looking for. So I think I'm curious about what we'll expect as far as outcomes from our partners, right? And what this and how will that benefit us? And I just want us to caution that this framework is a great start. It's going to have to evolve a little bit as we get more experience and we try to understand how to apply it and what it really means. So I don't want us to be fearful of getting it wrong or making mistakes, because that's really the only way to really partner and innovate with local organizations and really try to make an impact here within our boundaries. And so, but I mean, yeah, when I've wondered how are we making these decisions, and I love the fact that we're not trying to convince people to move up in the scale, like bring what you want and bring what you need, and we'll be able to determine where that fits. And secondly, that it's not just based off of relationships, that it's actually going to be based off of policy. It's going to be outcomes and really being mission and value driven. So thank you so much. I really appreciate it.
Yeah. Well said, John. I'll second everything you said.
And I think there's a big missing piece here. And although Allison used the word a couple of times, community need is where it starts. And determining, figuring out what the community need is the basis of all of this. And I don't think we've done a very good job with that lately. I keep saying, let's hear what the community health assessment, let's get a presentation to our board from what the health department's done on community health assessment. Let's get something from the hospital on what they've done on their community health assessment. I thought our CHI data didn't tell us anything that was useful at all. Maybe you found some gems in there, but I didn't. But none of this makes sense unless we're responding to an identified important need in the community. And how do we get that incorporated in? It's either in inform or before inform. I'm not sure which.
It's in all of them. Right, so a big part of this framework, in order for it to be effective, we have to put in place practice of feedback loops that are intentional and consistent. And those feedback loops have to happen at every level of investment across the tiers. So I would say that we have a pretty robust informed space. When I conducted the internal partnership assessment, we have a lot of partnerships and relationships, but they're ad hoc, right?
Yeah.
And so there's some work to be done in order to organize and start to think strategically about how those are actually moving in the direction of mission fulfillment and strategic priorities. And those are where a lot of those emerging community needs oftentimes come up, are in our sharing and caring meetings. They are in our going to the Murphy Center once a week and having conversations with folks who are receiving services there. So there's a lot, in addition to more formalized, obviously, assessments and data, right? And I think that that type of practice needs to be built into this framework overall. You're exactly right. We're not going to be responsive to something if we don't know it's there. And we have some muscle to build in that work as well. But we have a really good outreach and engagement
That's great.
space.
That's good. I appreciate it. One more thing I was gonna add. I want you to just think about this. I don't want you to do anything about it. I just want you to think about this.
Okay.
I was looking for something that would, because you're very clear that investment does not just include money. It includes staff time, relationship building, coordination, et cetera. And yet, if you look up the definition for investment, it's always financial. And I wondered if you might want to change it to something like partnership, investment, and collaboration framework. Something like that. You can come up with a better one, I'm sure, than I can. But investment will put people right in money. And it's more than that.
I would tend to disagree.
You do.
I don't necessarily feel like it's just about money. I think that investment means partnership. I think it means there's all sorts of ways to invest.
Sure.
And so
I agree.
I also think in
agree.
your previous statement, while I understand that there's a connection related to community need, I think that this is an internal process of being able to have a rubric, being able to have a framework of how we make decisions. What the community brings to us has to be well informed by our community partners. And also, we're in all of those spaces, so we know what we're identifying as community needs and how is that going to be aligned with what partners are bringing to us for us to score and see how it fits into how we can potentially partner, fund, whatever it may be. So,
Well, and I would add to that, that because I think the timing of this framework is really helpful and important, because you're right, like our strategic plan is not focused on community need as much as we would like it to right now. It's a lot of putting the systems and foundation in place in this organization and to set us up to be able to do that really well. But we're on the cusp of another strategic planning process that will hopefully connect well with community need and build that into that process, where then now we have a bit of a rubric to go back to and say, okay,
Absolutely.
yeah, so.
We just want to highlight the community on both like the qualitative and quantitative. So sort of why we're behind on the quantitative is when you're talking about the vacancies earlier, part of that was I think within the data team and trying to or working through getting that to you before the retreat, which I think Brian put into his
Yeah, I
executive director
have an
report.
update.
But also by shifting some of our positions within the community engagement team, especially there's one that is now a community weaver, and our position, our wonderful, Kamiga. He is moving into that position on the north side and really digging into the storytelling and learned lived experience of folks in Fort Collins, mostly our historically marginalized folks. And being able to weave that quantitative data with the qualitative data to create that's right what community need is.
So I have a question and or comment. Can you go back a slide to 2027?
Yeah.
So I guess what I'm curious about is based on something that came up last year, which is like how, like, to me, this actually looks like a lot of building on relationships we already have. And I'm wondering, like, what if somebody is not connected to us? Like, what is their invitation? What is that, like, call for applications or something like this, so that if somebody doesn't have a relationship, but they are aware of us and they are aware that we're looking for partners, like how do they know how to come in and ask, ask for some level of investment?
It's a great question. We've been thinking about this a lot. As someone who's been on the funding side of an organization, I get a little nervous about the procurement process for this. I think that we want to learn what type of relationships bring in new ideas, new perspectives, and new opportunities for the folks that we serve. And that will be part of this year. And it may result in a recommendation to this board on more formalized procurement processes like an RFA or an RFQ or an RFP that would allow us to make some of those decisions. With that being said, the partnership viability assessment tool that we've developed and have, we think really provides a strong foundation for this practice will provide a bit of edification for staff and for others to understand where we are positioned really clearly and really consistently, because I think that's been our biggest challenge, is that folks may be interested in partnering with us, probably more interested in getting funding from us than anything. And this will allow them to understand with a lot of clarity where we stand, where our priorities are, and where those alignments for partnership on any point of that continuum may be. So
Yeah, a lot of that comes back to some of the things that we would have in the tool that we don't have clear right now are based off of like your mission, vision, values work, and then creating a strategic plan that has clear community like impact goals. So it can help us position ourselves of here's where we're focused and here's why. So folks can see that and understand their level of like immediate alignment or not. Without that, we sort of continue to operate in that space of sort of like that nebulousness of where are we and are you just funding those folks that you've already had a relationship with? And we're hoping that through these different processes, probably over like the next 9 months, that we are doing more learning. Y'all are giving us those directions through strategic planning and mission, vision, values work. We're all to bring that all together to have way more clarity for those that we may have not touched within that continuum before.
Yeah, I think that'll be really important. I mean, this organization has shifted away from let's stop being a mile wide and an inch deep to being let's be more focused on certain things and get some real impact, which I agree with that approach. But as people are creative and have ideas and want to, have partnerships with us, I mean, they might want to pilot something, but right, how do they know when to approach us, what that looks like? Are they aligned or are they not really quite aligned?
Yeah, absolutely. So the goal, I think there are two parts to this. The first thing being, we hope to have, the part of the budgeting process present opportunities for funding that is in more of that emergent piloting type of opportunity. And I think that by having a clear set of funds dedicated to that type of approach, then it will allow us a little bit more, specificity in our outreach approach.
Great.
The second thing being that we need to continue to refine messaging externally for folks who are interested in working with us that are outside of our typical, our STPs, our same 10 people, right? In order to
That's good.
in order to kind of bring in a new audience for that type of work. And we need to be ready for that, and we need this process to be approved in order to make that happen. So we're taking steps toward that. I certainly hear that for sure.
And the hope that our teams are embedded well in the community in front of these conversations and a part of these diverse conversations that aren't just the STP in the choir, but actually we've strategically and intentionally sort of focused in different areas that connect to health, connect to our mission, and we have, relationships building there and more work to do for sure.
I just have one, it sort of piggybacks on I love this as a scaffolding, like a rubric. It really does, because we have so many different types of partners. It's so wonderful. I'm sort of a visual person, and this kind of creates, like a little map for me to sort of see and understand our different types of partnerships. And And in regards to the collaborate, one of these, it might be a one-time situation, and which are more likely to be potentially folks who are they're not our long-term partners, but are aligned in our vision and maybe have specific needs. And I'm just curious, just as far as making sure that we have equal access and information that is clear and out there, are you guys thinking about putting something on the website for partners that they can come and see kind of a bit of this understanding of our scaffolding, and for folks who are newer to collaborating with us, what that can look like, and having like an application, almost like an application where they can apply online, so that just so that the door in feels like it's the same for,
So
you know.
part of on the application, the external communication, yes, we've been communicating with Marcom quite a bit over the past 7 months of what that looks like. Part of it is waiting for the new website and where we can direct them and have everyone on the same page of what this framework looks like, before we put it out to everyone else. On the application, that's part of like this learning year, figuring out what is needed, what policies have to change, how are we in alignment, because currently we'd have to follow the exact same procurement policies that we have for a vendor to do our lawn care. So I think we have to think about it a little bit differently and do it in these iterative steps to be able to make sure that we're doing it intentionally and we're not accidentally causing harm by being well intentioned.
And I think to the first part of your question, around like, how do we know what investments we're making in this space? We're partnering very much with finance in terms of being able to be really clear about at what investment or at what level are we making investments and where are we spending dollars in this space, especially as it relates to the higher tiers of the work, so that we can track that and understand like where are these funds actually being distributed? Are we off balance? What does that look like? Continuing that like continuous cycle in that.
Yeah, and outcomes, that each tier is going to be a bit different on how we track outcomes, but that being a part of it, but it does, the scaffolding helps us sort of see the differences of each of those
And then
levels.
also that our realm doesn't own all of those partnerships either, and being very clear on that. Because there's a lot of work that gets done over in the community health services that really is about partnership. So we want to make sure that we are good partners in creating a framework that everyone can understand internally, externally, and knowing that we are creating this architecture, but the ownership lies within different places and spaces.
But I think tangibly for like the budget process, last budget, we were like, here are the people that we're gonna continue to partner with. And we might need a little flexibility without any real clarity. I think I'm hoping that the next budget process, we can say, well, here are the people that we're currently partnering with, and these are the designated dollars for maybe some of the different levels.
Yeah,
So that
yeah.
we can then invite in, as opposed to just kind of be like,
We'll
you
see.
know.
Yeah,
Yeah.
Just wait and we'll tell you when we know how we'll fill those dollars, as opposed to we have criteria of
Yeah.
what that would look like.
If we're ready for that.
Yeah.
We are.
Okay.
Yeah, we're very excited.
Yay, good work.
I think with the application, the framework is super helpful
Yeah.
for us to all be having shared language and shared expectations of how we're gonna sort of come to these decisions before we get to a public application process, which again, this framework is not meant to keep us so rigid that we can't be responsive when with urgent community need or the loss of a meaningful service. And so I just want us to be careful on the standard process that we go through, because if we have an application process, is that the only way to get
Right.
dollars through us? And if an urgent thing happens and an application's not completed,
Yeah.
can we not consider that? So I think there's
course.
more discussion
Absolutely.
around, certainly we need to get messaging out to the community and
Yes.
let them know we have a framework. We're looking at standardizing how we partner with the community, and here's a contact to reach out to on our website, if you're interested in partnering, so we can have a discussion before we get to that next step. But ultimately, that may be where we get to.
That message of we welcome new partnerships.
Yes,
Yeah.
and
That's
we
the
have
message.
standardized approach,
Yeah,
but not too rigid.
Yeah. I
not,
think-
yes, and community health is solved in a lot of different ways, and maybe a traditional partner
Yes.
there may be a non-traditional partnering conversation that leads to meaningful impact that we otherwise wouldn't have been exposed to.
And that's why I keep going back to the phrase, like, the goal is to get firms that can adapt to emerging communities without abandoning discipline.
Yeah.
Because then that's when you abandon that discipline, is when you accidentally move into inequitable practices.
Yeah.
Yeah.
That's true.
Frankly, I would have been concerned if I would have seen an application before I would have seen the framework.
Absolutely.
Right.
Mhm.
So,
Totally. They go
and
hand
I
in hand.
appreciate finalizing partnership with policies, because I think too often organizations practice drives policy, and in some ways, if we can slow down and really think about the policy and how it needs to support practice, I think that's gonna really cut down on vulnerability and any of the liability that we could walk into.
I have loved this conversation and I'm looking at the clock. So wondering if anybody has anything else burning that they want to say quickly.
Thank you so
Catch you later.
much.
Thank you.
Thank you.
Thank you
Appreciate it.
guys. Thank you.
Appreciate it.
Thank you.
All right, so we are moving into Board of Director reports, liaison to PVHS report and executive director report. And I would invite the board to give as brief a report as possible, like 30 seconds would be rad. So
I'll start. Oh, I was
Okay.
gonna say I'll start.
Okay,
'Cause
go Julie.
I'm taking your challenge. Governance committee tour of the property that is next on the agenda.
That plus I went to the employee picnic.
Oh, good.
All right.
Good. It's gonna be mentioned a little bit later, but Tom Gonzalez contacted me and said, I think you should hear this podcast that we've done with Brian. And so I appreciated him reaching out to me, and I listened to it right away and said, you all should listen to it. It's really good. It's well done. He's gonna mention it, but I wanted to give it a plug.
Okay.
I'll stop there.
It was awesome.
Sarah.
Quick shout out to our community health centers. The first week of August was our community health center celebration week. So, and Salud being our awesome partner here in Northern Larimer County.
Good.
And I got to tour the property that we'll be discussing, and that was very exciting, and look forward to more discussion on that.
You can say the address too.
Okay.
It's in the agenda. It is, yep.
The only thing in the community that I've been able to do recently is I went to the annual event for Sunrise Clinic this week, and it was
It was
an
awesome to
excellent
see his face
celebration.
there.
So if
Yeah.
you want to see pictures of Sarah competing in the Olympics, please reach out to me directly. Also, as far as the PVH, really good stuff. I had pages of notes that I could go into, but really more than anything, urgent cares collectively in the region have seen 563 patients a day. And so with McKee closing, there's been just an increase. And that Pruder Valley Hospital is 1 point away from being on the US news and report for distinguished hospitals. It's really hard when your volume is low because they centralize at UC Health. So let's see, MCR is a place that they send a lot of people for specialized services. So it's really hard to get those points up, but it just shows that PVH is a real impactful, a great service to our community here. So that's it.
All right, thanks. All right, Brian, I don't want to short you because you have important things to say.
I do. I can keep some of this brief. I will just talk about some upcoming meetings that I'll be attending. So a legislator town hall this Saturday with Senator Kathy Kipp, Representatives Andy Besenegger and Yara Zokai. So, and then the Cultural Enrichment Center is hosting an open house at their location this Saturday, and I will drop by that. So I will highlight a couple key updates. So we talked about budget positions. We have made some key hiring decisions here recently, which you'll see reflected here. So we are adding some great new staff to the team in some higher level positions as well. One of the key updates is a new senior executive assistant and board liaison, with which you all get to know. So Rebecca, she starts on Monday. So Jackie and Carolina will be supporting our senior leadership team moving forward. And then Rebecca is taking that senior executive assistant and board liaison role moving forward. So that she will be your point of contact. I will help do some onboarding for you all to make that transition smooth. Yeah, the all staff picnic was awesome. Shout out to staff, everybody that worked on that. Thanks to Aaron for being there. I don't remember if you got a Kona ice, but
I did.
okay, great. The CHI update, so Lee mentioned this, you know, the CHI data from for Larimer County and for the state was released. We are still working on some more specific health district boundary data from CHI as part of our contract with them. So we will get some of those data points to you all before the board retreat. So more to come there. It's not all out yet, so there's more coming. So working on our new website launch, which has been pushed back a little bit. We're looking at mid-September for launching the new website, but really excited to get a fresh new website with good, meaningful information focused on clients, community. Yeah. Okay. John did a UC Health update, so that's great because I met with Kevin. You talked about the podcast. Thanks for listening. I appreciated Tom inviting me to do a little Health District 101 and Health Department 101 and try and you know, learn more about two agencies that often get confused for each other. So and then just upcoming, we have our board retreat on September 9th, Wednesday. We'll start serving lunch at 11:30 and we'll go to 4 at Spring Creek Gardens. Okay. And I've got to do some kudos. So a shout out to our comms team. We sent out our annual report to you all. It looks fantastic. I don't think we've seen an annual report like this. At least when I worked here previously, like this is great work. I think it's really valuable and helps sort of tell the story of 2025 for our services and our impact in the community. So thanks to the comms team.
Yes, thank you guys.
We talked about our team working on sliding fee scale, partnership framework. Again, tonight's theme is sort of like standardization and policy and process. And that's so, you know, just really time intensive big lifts for us to sort of do that foundational work that doesn't always get a ton of excitement and notice in the community, but it's meaningful and helps set us up to be able to do that meaningful work. So also shout out to this campus search process and the team, Jessica, Mike, Jackie. There's been a ton of behind the scenes work around that whole process, due diligence, everything. And then our HR team, because we have added you know, quite a few new folks and done recruitment, and they've been doing a lot of onboarding lately. So there's my kudos. Now I would like to shift into a little bit more discussion, actually just some remarks, given the topic that we're going to talk about tonight with the potential for the health district purchasing a new property, potentially moving our campus to a new location. It's a big discussion, and for the sake of transparency, I wanted to provide a little more context to the community and the public of how did we get here to this discussion and potential decision point. And then we're gonna offer a second public comment after that context. So this I can't rush through. I have prepared remarks because I think it's really important, given the history of the health district and importance I know what this could potentially do for us and how we could serve the community with this type of decision. So I want to get through my remarks. So before we open our second opportunity for public comment and the board moves into executive session, take a few minutes to provide some context for the community about how we arrived at this point. So for the board, a lot of this will be familiar. We've had some discussions about our long-term facility needs and evaluating potential options for some time. Because a lot of that work has occurred over a number of months since I started, and because real estate negotiations, rightfully so, require some confidentiality. I think it's important, and the board thought it was important that we provide the public with some additional insight into why we began looking for a new campus, how we approached the search, and why the Oak Street Canyon property emerged as an opportunity that we believe deserves serious consideration. So why we started looking, at its core, this process has not simply been about finding a newer or larger building. It's been about asking a much larger question. What kind of physical environment will the health district need to best serve this community for the next 10, 20, or even 30 years? Our current buildings and facilities have served this organization and community very well. As our services and partnerships and workforce community needs have evolved, we've increasingly encountered limitations with our existing Bristlecone campus. We began looking at whether there was an opportunity to create a campus that could bring more of our staff and services together in one location. A lot of benefits to that: culture, communication, collaboration. Make it easier for community members to find and access our services, create a more welcoming, accessible, and integrated experience for our clients and families, provide greater flexibility as community health needs change over time, create better spaces for collaboration among our staff and community partners, give us room to evolve without repeatedly having to solve our space needs one program or one building at a time. And ultimately, we are out of space in the Bristlecone buildings. So how we've approached our search, we've looked at it really as a long-term investment, rather than simply a real estate search and looking for a property. So over the course of this process, we've evaluated potential properties against a number of priorities and criteria. We were looking for a property large enough to bring our organization together while also providing appropriate parking, accessibility, visibility, proximity to transit, and flexibility for future needs. We also wanted to remain connected to the community we serve and avoid making access more difficult for the people who rely on our services. As most people know, there's relatively few properties in our community and in this immediate area that meets that combination of requirements. We did explore multiple possibilities over the course of the search. Some didn't meet our needs, others presented challenges related to location, size, costs, timing, long-term flexibility. But the process has been deliberate and intentional. We've tried not to start with a particular building and convince ourselves that it works for us. Instead, we started with what we believe the health district will need in the future and evaluated properties against those needs. So Oak Street, Oak Street Canyon Avenue, represent a particularly compelling opportunity because they address many of the priorities we identified at the beginning of this process. The location keeps the health district centrally located within Fort Collins in our boundary area and connected to the broader community. It provides an opportunity to consolidate more of our operations and services into a unified campus. It offers the size and flexibility necessary to think beyond our immediate space needs and design around how we want to serve people in the future. And importantly, it gives us an opportunity to intentionally design a campus around the experience of our clients, staff, partners, and community, rather than continuing to adapt spaces that were designed for different purposes. I've talked to the team a little bit about this and said this several times. I'm not one for symbolism, but there is some cool symbolism between bristlecone trees and oak trees that I thought was sharing. So bristlecone pines are one of the oldest, most resilient trees on Earth. They survive harsh conditions, they endure for thousands of years, and they develop deep strength over time. Oak trees symbolize growth, shelter, community, and longevity. Oaks spread wide, create gathering places, and support entire ecosystems, creating habitats for thousands of species. And we feel like that messaging resonates strongly with how we want the health district to support and show up for the community in the future. So what could this mean for the health district and for the community? Our long-term vision is for a health district campus where someone can come to us with a health need and have a much easier experience navigating the services and resources available to them. Rather than expecting people to understand which program, department, building, or organization they need before they walk through the door, we have an opportunity to create something much more integrated and welcoming. That can mean better connections between behavioral health, dental health, insurance assistance, care coordination, and other health district services. It could mean more opportunities to collaborate with community organizations and partners. It could mean spaces designed for education, community engagement, prevention, outreach, other needs that may emerge in the future. And it could give us greater flexibility to respond as the health needs of Northern Larimer County continue to change. The opportunity is not simply to move our existing organization into a different building. It's to design a campus around the organization and the community that we want to become. There is another important part of this strategy that I want the community to hear and understand. The health district currently owns multiple properties. If we move forward with the Oak Street campus, our intention is not simply to add another property to that portfolio. Our intention is to manage our real estate much more intentionally and strategically. Consolidating more of our services and operations into a single campus creates the opportunity to evaluate and ultimately sell multiple properties that the health district would no longer need. The proceeds from those sales could help offset a meaningful portion of the costs associated with acquiring, designing, and developing the new campus, an important part of how we're thinking about this investment. Our goal is to make sure that every asset the health district owns has a clear purpose connected to our mission. We do not want to maintain buildings simply because we have historically owned them if there's a better way to organize our services and use those resources. So by consolidating our real estate footprint, we also have the opportunity over time to reduce some of the duplication that comes with operating and maintaining multiple separate properties. And actually overall, our building operating costs will be less operating this campus versus our existing properties. So the health district has been part of this community for decades. Decisions like this should be made with a similarly long horizon. If we move forward, we would view this as an investment in the health district's ability to serve Northern Larimer County for generations. That means asking whether this property gives future boards, future staff, future community leaders enough flexibility to respond to needs that we may not even be able to fully anticipate today. It also means being thoughtful stewards of the assets the community has entrusted to us, using our existing real estate strategically, reinvesting the value of properties we no longer need, and avoiding a situation where we continue investing public dollars into a collection of facilities that may no longer represent the best long-term solution. At the same time, we recognize that acquiring a property of this significance is a major decision involving public resources. It deserves careful scrutiny, transparency, and thoughtful consideration. I want to close by emphasizing that we see this as much more than a building decision. This is ultimately a decision about how we position the health district to serve this community for the next generation. It's an opportunity to create a campus that's easier to access, easier to navigate, more integrated, more collaborative, and flexible enough to evolve alongside our community for decades to come. It's an opportunity to be more intentional about the real estate the health district owns, consolidating where it makes sense, selling properties we no longer need, and reinvesting those resources into a campus and services that better support our mission. The Oak Street property presents a unique opportunity to move toward that vision. So with that context, we thought it was important to provide another opportunity for public comment before the board considers the matter further. So I'll pass to Erin.
Right. At this point, we welcome public comment. Is there any public comment in the room? So if you are online, we would invite you to raise your Zoom digital hand to indicate your interest in giving public comment, and we'll give you a few moments to locate that button and activate it. Because this really is a big decision, an important decision, and we'd love to hear from the public if there are any comments that you would like to make on this. We'll just give it 10 more seconds. Yeah. No hands. All right, so we are seeing no public comment requests online. So that will close our second public comment opportunity. And now we are going to move into our next item on the agenda, which is an executive session. So at this point, I need to read some special
Karen,
language.
before you do that, could I say one thing?
Sure.
I would like to thank Jackie for the wonderful service that she's given to us. She was delightful to work with. She was very responsive, very competent, very professional. And I just want to say thank you, Jackie.
Yeah.
Thank you, Jackie.
Thank you for that. Yeah, Jackie stepped up at a time in this organization where there was a lot of need and transition, and she did a fantastic job helping support Courtney and interim and this board through a lot of changes. And yeah, so we're all grateful and thankful for Jackie's experience and her commitment, and excited that she's going to continue to support our leadership team moving forward. So yeah,
Yeah.
thanks for recognizing that.
Yeah. Ditto. Thanks. All right. So I'm going to read all the words now to go into the executive session. So I am looking for a motion to go into executive session pursuant to CRS 24-6-4024A to discuss the possible purchase, acquisition, lease, transfer, or sale of real, personal, or other property interests related to the district's long-term campus expansion and facility planning needs, including the evaluation of potential properties and associated strategic considerations.
So moved.
Okay, Lee makes the motion.
I'll second.
Sarah seconds.
We have
All those in favor say aye.
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 Any opposed? So that passes unanimously. So at this point, we're going to stop and do some logistics where people leave the room. And then we'll go into our executive session, and then later we will come out of the executive session and finish the agenda. Okay? All right. At 8:19, and we resume the regular meeting at 9:20. All right, I see Julie, I see Ellie. We're just getting all squared away with the tech on this end.
Okay, I'll be back in 1 second.
Okay.
Sorry about that. We
No
are ready
worries.
Whenever Julie is back.
Yeah.
You don't have to wait for her. You're welcome to, but you still have a quorum, just to point
Okay.
that out if you'd like to resume.
All right, have you restarted the recording?
Yes.
Okay. The time is now 9:20 PM and the executive session has been concluded. If any person who participated in the executive session believes that any substantial discussion of any matters not included in the motion to go into the executive session occurred during the executive session, or that any improper action occurred during the executive session in violation of the open meetings law, please state your concerns now for the record. Hearing none, sorry. Hearing none, we will go back to our next agenda item. It's an action item for approving the purchase contract for 315 West Oak Street and 211 Canyon Avenue properties. So we have a resolution in our board packet that is 2026-10. So are there any comments on this?
Should we do a motion first?
Do we have a motion?
So, oh yeah, I can do, I can ask for a motion when I've asked for the motion before, then people get kind of upset that, anyway.
It's the right thing. It's the right.
I know it's the right thing to do. Do I have a motion for approval of resolution 2026-10 as presented?
You're gonna do
So
it.
moved.
Sarah.
Second.
Lee, seconds. Okay, so now we can move into discussion. So we have this resolution. What would the board like to say on this?
I just think this is a great idea and it's important that everyone's in a consolidated space and in a good location and this is really definitely the right thing to do.
Yeah, the things, it was a great discussion and, the things that so really resonate with me and why, I feel like this is the right move is that, I think there are some massive benefits for all staff being under one roof, the ability to collaborate amongst ourselves, having space to even, very creatively and effectively collaborate with partners, with the having some extra space that we can utilize in that way. I love that about this property. The accessibility being off the max and with a lot of access to public transportation. And the fact that, well, and there's also, just to kind of reiterate about the staffing under roof, I'm hearing from leadership and folks on the ground that there's quite a bit of support of this. So accessibility, excitement of being under one roof, accessibility for staff for this location. And lastly, that we're able to kind of do all of this and financially have a plan in place that allows to keep a healthy fund balance. So, yeah, those are my thoughts, kind of in much of a nutshell as I could.
Yeah, I would say, certainly everything that has already been said, but this really does make real that vision of having a single campus and having everyone together, which is something that we've been talking about for the majority of time that I've been on the board and the folks that have been working hard to make that happen. I really found that Brian's introduction of the issue, I think, put it in stark contrast, which is we are here now because we are fiscally responsible. This maintains that fiscal responsibility and carries it forward. We are creating a higher level of presence in the community through this action. We are making ourselves more available to people in the community, and we are connecting with partners in all of the ways that we talked about even this afternoon or this evening in the initial meeting about creating those strategic partnerships and making sure that we are using our funds wisely. So putting this package together where we are buying what may seem like a very expensive property is actually an investment, not just in the health district, but in the community. And it shows the longevity of the programs that we have put in place and the immense upside future that we all have and see as we continue down this path. So it's thoughtful, it's strategically important, and it is completely fiscally responsible. And I think the taxpayers should be assured that we are using their funds and husbanding their funds wisely and well. Even though this looks like a big outlay, it actually is something that is an investment in our future and in the health district of Northern Larimer County. And that means it's an investment in the health of our community.
Thank you, Julie. I also support this resolution. I'm very excited about how this sets us up for the future. I think I appreciated Brian's remarks on this a little while ago that like by bringing everyone together, there's going to be synergies both with staff and, you know, with partners. And then we'll get some side benefits of streamlining operations and cutting some of our operating costs. So that's good because we have a plan or, you know, some considerations that we'll do around all of our assets. As Brian mentioned in his report, right, like, yes, we're getting this property and then we're going to evaluate what we do with our other assets. So I think that we're taking a very responsible approach. We're looking at different projections for the costs and the expenses. And I feel comfortable that even in the worst case scenario, that we will still have a healthy fund balance. And that we will have cash on hand to continue serving the community in the way that we need to serve the community. So I think that's all really on the up and up. And I think it's just going to be so fun to get everybody in one building and then, you know, do fun things together. So I think this is just a really exciting opportunity. And we didn't really know a few months ago that this opportunity was going to come up, but we had this guiding light about having the single campus and making it easier for people to access our services and making it, you know, just making it easier for people.
Yeah.
That's what I want to say. And so I think this goes even more in that direction and really supports us in doing this important work in the community. In a building that's really going to support our work.
And the other thing is right now, we don't have the space to do the services we need for this community, and this will give us a space to do that.
Right. Yeah. Yeah. Thanks for saying that. Yeah. We're bursting at the seams. We don't have enough space.
Limits who we can hire.
Yeah. Yeah. And that we alluded to that earlier. Like we don't even have space to hire people.
And who we can serve. Right.
Yeah. We're all kinds of constrained right now.
Yeah.
Any other comments that we want to make before we call for a vote on this? All right, hearing none. All those in favor say aye.
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 Aye. Any opposed? None, so that carries unanimously. And just a note on the record that that Director McKay had to leave, and so he's not present at this moment, but it's a unanimous 4-0 vote. So then we move to the part of our agenda where we adjourn. Do I have a motion to adjourn this August 19th, 2026 Board of Directors meeting?
So moved.
So moved.
Okay.
Right there.
I was trying to get in.
You can second.
All right, Lee
Okay.
moved and Julie seconded.
Sure.
All those in favor say aye.
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 Any opposed? All right, the motion carries 4-0 and we are adjourned at 9:30 p.m. Thank you, everyone.
Thank you.
Thank you.
Longer sessions here.
Thanks, Ellie.
Thank you, Ellie.
Bye. Thanks, Ellie.
Julie.